Good afternoon or evening, depending where you are in the US today. But thank you for joining us. My name is Susan Evans, and I am honored to welcome you to today's webinar featuring the Alzheimer's Association, Lewy-Body Association, and Parkinson's Foundation. Super excited to have them today as our guests. And thank you, Kensington, for supporting these powerful educational events for our aging community. I was first introduced to Kensington in 2015. Our family made a difficult decision to move my father to Kensington in Northern California. He was living with Alzheimer's and it was greatly impacting my mother's health. And I did not want to lose both my parents to this dreadful. And as it turns out now, my mother has Parkinson's. My life pivoted and did a 180 from being a recent empty nester to dedicating my efforts to education and connecting the Alzheimer's community. Kensington focuses on relationship-based care built on the foundation of our promise to love and care for your family as we do our own. It is programs such as the ones you are attending now that are so important for those of us walking through a caregiving journey to hear from these expert professionals on keeping us current with the latest advances in care management and treatment of conditions that affect seniors and their families. We are truly privileged to support care partners and professionals from coast to coast. And I understand we have a lot of professionals on our webinar today. So I encourage everyone to please utilize the Q&A function to submit questions during the webinar. You have an amazing panel. Please utilize all of their expertise. A copy of today's webinar will be delivered to your inbox in the next few days for you to share with friends and family, and of course, watch again. Please join me in welcoming Claire Day, Keith Fargo, and Connor Courtney. How are you?
Doing
Good.
well.
Good. So what we're going to do is we're going to start with just a brief introduction from each of our panelists and presenters. And Claire, can we start with you, please?
Sure. Happy to be with all of you today. And thank you so much for the kind invitation, Susan and Kensington. My name is Claire Day. I'm the Chief Mission and Program Strategy Officer with the Alzheimer's Association in Northern California and Northern Nevada. And I oversee all of our care and support operations here at the chapter. And we do serve all states in the United States through chapters locally.
Okay. And next, how about Keith? Can you share a few words about yourself, please?
Yeah, sure. First of all, thank you also for the invitation to Kensington today. Really happy to be here and able to talk a little bit about Lewy body dementia to the folks joining us. My name is Keith Fargo. I'm the Director of Scientific Initiatives at the Lewy Body Dementia Association, and I oversee our grants program and our various other research programs there in that role. So, thank you.
And Connor, last but not least.
Thanks, Susan. I'm Connor Courtney. I'm the Associate Director of Research Programs here at the Parkinson's Foundation. I just celebrated my first anniversary here at the Foundation, and what a good year it's been. Previously, I was conducting Parkinson's-related research for several years at Northwestern University. And I come to you all today as someone who has a little bit of scientific experience with Parkinson's, but also, perhaps more importantly, experience as a caregiver, as my father has had Parkinson's for 13 years, and I am his primary caregiver. So have a bit of experience on both sides of the coin, and happy to answer any questions on either perspective here today.
And I think you bring up a really good point, and I want our audience to think about this because each of these brain diseases are so closely related yet so different. But I think the caregiving challenges are also so different because I'm sorry about that, Connor. My mother has Parkinson's, and sometimes I don't know which base to be on. And it was similar with Alzheimer's with my father, yet so totally different and different challenges. So I'm so excited that everybody's here today. And we're going to start with Claire. And then so we're going to kind of go around the room, start with Claire, then Keith, and then Connor, and really talk about the diseases and how they're different. But I think Claire's going to lay a little framework for all of us in understanding how under the umbrella of dementia they are related.
Yeah, I'm just going to go ahead here and share my slides and hope the technology is my friend. today. So if Susan, if you can give me a thumbs up that it looks the way it's supposed to look from your end,
It's
great.
perfect.
Well,
Perfect.
again, thank you so much for the ability to talk a little bit about Alzheimer's disease biology and how it might be a little bit different from Parkinson's and Lewy body. And I think that's what's so great about this presentation is that we often talk a little bit of, we often hear people talk about the word dementia, and it sort of gets misused at times as sort of an all-in-one type of a word, and it is, right? So dementia really is that umbrella term, defines the loss of the loss of function, really of enough severity that it's impacting our ability to do our activities of daily living, like bathing and dressing, going to the grocery store, managing our finances. So it's really that collection of cognitive symptoms, of behavioral symptoms, even sometimes psychological symptoms. And as you can see here, if you look under the umbrella, and I always like to think of the word umbrella, replace the word dementia with the word flowers, and underneath you would see tulips and daffodils and roses and carnations, all different types of flowers. It's the same with dementia. We see that umbrella term really referring to the loss of memory and thinking, but the biological change that's happening in the brain is going to vary depending on the type of dementia that one might have. And so as you can see here, we are going to talk about all of these different types, including Lewy body and Parkinson related dementia. And I think oftentimes people talk about the word Alzheimer's a little bit more because it's the most common, but really it's important to understand what that underlying biology is. And it's important to understand from diagnostics perspective, from a treatment perspective, and from that caregiving perspective, as Susan talked about in the beginning. So let's look a little bit into under a microscope to look at what Alzheimer's disease might look like. Alzheimer's is defined by 3 hallmark changes in the brain: the presence of beta amyloid plaques, tau tangles, and neurodegeneration or nerve cell death in areas of the brain that are really important for those things like cognition and memory and behavior. The neurotic plaques, also known as beta amyloid plaques, are a buildup of a protein that sits outside the neurons of the cells in our brain. There's another type of protein called tau, and changes in the tau protein can actually cause this tangled web, which is why you hear these hallmarks known as the plaques and the tangles. Inside the cell, that decreases their overall neuronal cellular communication, the ability to transport chemicals and nutrients across that cell. It's sort of this phenomenon that's associated with or relieved to contribute to the overall neuronal death that occurs in our brain. And so it's really, I think, important for us to think about the biology of Alzheimer's disease as that, a change in the brain because of what's happening in the brain. And you can see in that third image that very distinct difference between a healthy brain and an advanced Alzheimer's brain. But I do think it's also important to understand the different types of biologies of these dementias that could be causing those dementia symptoms. And when we think about Alzheimer's disease in particular, we really think about the disease itself on a continuum. And part of the reason that's important to think about is because there is this period of time that we consider ourselves to be asymptomatic, where you would not see the symptoms of dementia, so those changes like memory and functioning and reasoning, but the biological changes may already be occurring in our brain, and it's thought to be that could be occurring up to 20 years before we ever see any of those symptoms. And as we're learning more and more about how Alzheimer's disease is sort of on this continuum, it's really been important in the discovery of treatments and when we start to think about early detection and diagnosis. And so what we tend to see is that people with Alzheimer's disease will start to show the symptoms of what we know as mild cognitive impairment due to Alzheimer's. This would be due to the biology of Alzheimer's, where we see some of those symptoms of cognitive decline appear, but functioning remains high. And then as we start to see the progression on this continuum to mild, moderate, or severe, where you start to see more of the symptoms interfere with daily living in those stages, this is where we would start to see that word dementia really used, where we're using the loss of function, right, of enough severity that it's impacting our daily living. And so when we think about mild cognitive impairment, everybody who has Alzheimer's disease or will pass through mild cognitive impairment, but not everybody who has mild cognitive impairment goes on to develop Alzheimer's disease. And so that's where understanding the biology and understanding what's different in a brain of someone with Alzheimer's is really important. And one way we're advancing that is through what I consider to be these game changers of biomarkers. And so a biomarker is a biological part of us that shows evidence of a disease. So if you think about the most simple test that most of us have had, a lot of people have had a blood test to say, measure our glucose level or our cholesterol level. That's a biomarker. The lab can draw our blood and can look at that blood and determine whether or not your cholesterol is where it should be, or if it's if it's a cause for concern. And so biomarkers are really starting to change the game for all of these different types of dementia and helping us to understand that biology without having to wait until autopsy, which has been up until recently the sort of only way to really confirm what the type of biology might be. And you can see here there are different types of biomarkers that are really being investigated when it comes to understanding how to use these with dementia. Certainly imaging like PET scans, and you can have a PET scan for either tau or beta amyloid, but even advancements with fluid biomarkers like cerebral spinal fluid, as well as blood tests that are really starting to gain some traction in research to make it so that we hope one day there would be the availability to use some of these tests for clinical diagnosis. We're not quite there yet to use a blood test as the marker in a physician's office today, but it is really showing you the trajectory of where the disease is going. And then there's some emerging markers like retinal scans that are in sort of earlier phases of research that are really showing that there is going to be a way to think about detecting early on the biological changes specifically to Alzheimer's, which will help when we start to think about treatments and other things associated with care and support. So I'm going to stop there and turn it back to Susan, and I think Keith is going next, but I can't remember.
I am here, but before you disappear off the screen, and Keith, you can join us right now if you want, but the biomarker about the blood test, it makes me think, gosh, could I go to the doctor and they say, oh, you have a biomarker for Alzheimer's or some type of dementia, if it could be that way, but is that going to be a really critical component in early detection and early treatment, in your opinion? Because right now, and I also want all of us to talk for a second about mild cognitive impairment and why it is so critical to not ignore early symptoms, but to go to your doctor and say, these are my, notes, because I'm sure Connor will agree with me. When it's your father, your mother, or whoever it is, you think, oh my God, I'm never going to forget this. And I've already forgotten half of the early, MCI traits that my dad displayed. So it's so important to take notes. But any thoughts on the blood biomarkers from any of you and where you think that'll take us?
Yeah, so I can start by saying I think for Alzheimer's, there have been a couple of really big advancements in the last couple of years that are really improving the accuracy of these blood tests when it comes to identifying specifically the biology of Alzheimer's. I don't know that they'll be the only tool that's used in diagnosis, at least not in the first few years. I think they will be a tool that is used to enhance diagnosis and to make it a little bit easier. And I think it all sort of comes together, like you were talking about, not ignoring those early warning signs. Part of the reason families sometimes take so long to get diagnosis because even if they see the signs, the testing has been primarily subjective, right? So they're
Right.
ruling out other things that could be causing the cognitive decline. So they might do a MRI or a CAT scan to look for tumors or for signs of stroke, but then they're doing those subjective tests, those memory tests. And so in those cases, it would be that additional piece of science that would actually give more conclusive evidence of a disease. I don't know for Keith and Connor, how that plays out differently with Parkinson's or Lewy body.
Yeah, I'm happy to start. So I'll say that, to my knowledge, there's not a blood test yet for Lewy body disease, either dementia with Lewy bodies or Parkinson's disease or Parkinson's disease dementia. But we certainly look forward to the day when there is, because we've been talking here about mild cognitive impairment, and Claire even mentioned earlier pre-symptomatic disease, or what we might call preclinical disease. In other words, that would be a state in which you have a marker showing that you have disease present, but you don't have any symptoms yet. So you can imagine heart disease, you can get a cholesterol measurement to tell you that you have heart disease, and you can know that before you have any symptom of heart disease, any, weakness, shortness of breath, heart attacks, etc. And they can start to treat you while you're asymptomatic to hopefully prevent you from ever becoming symptomatic. And I think most people working in neurodegenerative research today envision that as the future for neurodegeneration as well. That someday in the future we'll have tests, would be they hopefully blood tests, because that's the easiest and most widespread type of testing there is, to tell you that you're at high risk and that maybe we should do something to start treating that disease now before it ever even develops into symptoms. So I think, yeah, that's a blood test is a little bit of a holy grail for most of us.
Connor, do you have anything to add?
I was just going to say I fully agree, and I cannot overstate the importance of how great blood tests for some of these neurodegenerative diseases are in terms of biomarker development. So fully support everything you've said.
So I'm just going to go right into something that was asked by the audience, and that is, about how important is public awareness and education. But I also have a question I just want you to think about. You can answer now, or we can wait until the Q&A. But as Claire mentioned, you start getting Alzheimer's 20 years before you're symptomatic. So what does that pose a question? I don't really want to know at 40 years old that in 20 years I might, or at 45. I mean, does that jolt the whole, like, what do I do? And what are your guys' thoughts on that? Does someone want to jump in?
Yeah, I'll address that actually, if that's okay. I think it's a very personal choice whether a person wants to either get some kind of genetic testing that might tell them about some kind of medical risk, or biomarker testing that might tell them about some kind of risk. I don't think right now any of us would recommend that people run out and get, biomarker tests that are not yet, in widespread use in doctors' offices. And the reason for that is because they may not be medically actionable. And you might not want to know today that you're going to have Alzheimer's or Parkinson's disease or dementia with Lewy body in 10 years, but you might want to know that you were going to have one of those diseases in 10 years if there was a medication you could take to prevent it. So I think advances in treatments are going to make biomarkers much more widespread in the future.
And do all of you think that, I'll call it a cure, but I'm going to call it an antidote, like for AIDS, that it will be unique into each of, obviously, the brain disease that you have, and it will depend on where you are, like when you would start taking some type of an antidote. But I could not agree with you more, and that's why I said I wouldn't want to know if there's nothing I could do about it.
Yeah,
Okay.
and I think the other piece, especially for Alzheimer's disease, is what we're learning about lifestyle interventions as well, and how that would be something that, in collaboration with potentially a treatment, couldn't agree more about how, I think what we're starting to see with some of these successful treatments for the first time that are addressing the biology of Alzheimer's. The only testing that has been done with those is with people with symptoms. So yes, they have the biology of the disease, but they also have the cognitive symptoms of dementia. And so now the question is, do we start to think about clinical trials where using some of those new treatments with people who are asymptomatic? But I think a big piece of that will be that combination of also knowing what makes good risk reduction strategies within our lifestyle, and what we're learning from trials like US Pointer and other lifestyle trials that are actually helping us to identify whether or not there may be some protective benefit. And I don't think it's going to be one thing. I think it's going to be a combination of sort of all of these different types of approaches.
And we'll talk about that later because I want to get to Keith, but I want the audience to know that you have a modifiable risk factor and you have non-modifiable. So right now, my sex and my height and my weight is well, not my weight, but who I am born with, my genes, is non-modifiable. I can't really go out and change that, but modifiable are the lifestyle choices that you guys all mentioned about, diet, exercise, sleep. And I know that we'll talk a little bit about that, but I'm just going to say real quickly, I interviewed Dan Gibbs, who is a neurologist in Oregon. He wrote a book, Tattoo on My Brain. He diagnosed himself with Alzheimer's disease, and he changed. Really got into exercise. He really monitored his sleep. He did a complete 180 on his diet, and he will swear and is convinced that it really slowed the progression of his disease. So I think that's true for Lewy body, I'm sure, and for Parkinson's. But now we're going to let Keith take it away. Keith, the floor is yours.
All right, thank you. I will try to share my screen here, and I think at first it's going to pop up in slide sorter view, but we'll see if we can get it to go full screen in a moment. All right, do we have full screen here?
We have more than, yes, we do. Perfect.
All right, great. Thank you, Susan. I'm Keith Fargo, Director of Scientific Initiatives at the Lewy-Body Dementia Association. Really happy to be here today because there's a tremendous amount of overlap actually between Alzheimer's disease, Parkinson's disease, and Lewy-Body dementia. So it's really nice to get to present with some of these other folks who are focused on those diseases as well. And huge thanks to Claire for setting the stage for all of us today. Before I get into, I do have a slide on the biology of the disease, which I'm going to talk about. But before that, since we do have some professionals and caregivers with us here today, I want to make sure that I let you know about some of the resources that we make available to professionals and caregivers. So we have some educational resources. All of this is available online for free. Just come to our website, lbda.org, and you should be able to find all of this. One of the most important educational resources we have is something called the Lewy Learning Center. And that is an on-demand platform where you can take courses on your own at your own pace and whatever is of interest to you. And so here's a link to that. And you can also find that, like I said, simply by navigating to our webpage and doing a search for it. For the professional healthcare providers who may be on the line with us today, I want to point out a program that we've made available over the last year called the US-based Diamond Lewy Management Toolkit. And this is for medical management of people who are coming to your office who have Lewy body dementia. And that might be dementia with Lewy bodies, which is a form of the disease where people have the dementia symptoms and the movement symptoms come later. And you can contrast that to Parkinson's disease dementia, dementia, which is also a form of Lewy body dementia, where the movement parts come in first and you start to see those symptoms, and then the cognitive decline comes later. If people live long enough with Parkinson's disease, about 80% of them will develop Parkinson's disease dementia. This management toolkit, we hope, will make physicians' lives easier when treating patients with these diseases. We also have some educational resources for other healthcare providers, not just physicians. So for physical therapists, occupational therapists, and speech language pathologists, we have a course for them as well. And that's available on Continue Ed. People can find that through our website as well. Then more for people who are currently living with the disease or providing care for someone who's living with the disease, we have a program that we make available called Spark. And this is a short film about Robin Williams' journey. Unfortunately, he was never diagnosed during life with Lewy body dementia, but upon his passing, he donated his brain for autopsy, and they found that what was causing his symptoms during life was Lewy body dementia. And so anyone can watch this free of charge at mediflix.com, along with some other educational resources that we make available at Mediflix. And again, you can just come to our website and search for this, and you'll be able to find the links to that. I would also let people know that all of the webinars that we do, we make available forever on LBDA TV, which is which is on YouTube. So if there's ever a webinar that you see that we have given and you missed it, you can always go back and watch those on LBDA TV on YouTube. And finally, if you're in a crisis, or even more importantly and better, if you're looking to avoid a crisis and you need some help and some support from a licensed clinical social worker, we do have an 800 number that people can call. Or you can also send an email to support@lbda.org, and people will get back in touch with you. I'm going to skip this Research Centers of Excellence slide. This is more for researchers, but if you see this later and you're a researcher watching this, please take a look at that. More for patients, we want to make sure that you understand the clinical trials that are out there and how you can find information about those clinical trials. And so we have a program called Lewy Trial Tracker, and essentially that's a contact registry. So you would sign up there, tell us a little bit about yourself, what kind of research studies you're interested in participating. Are you willing to give, for example, a blood sample? Are you willing to have a brain scan, for example? And then we use your preferences and compare those to the clinical trials that are available today and send you information about the clinical trials that may be a good fit for you. Now, it's important to know we do not share your information with clinical trial teams. So if you see information from us about a clinical trial that might be a good fit for you, that's completely up to you whether you want to reach out to that study team to learn more about it. But it's a good way for you to get the information about these studies directly into your inbox without having to go hunt them down. So now I do want to talk a little bit about the biology of Lewy body dementia here. And, Claire talked about Alzheimer's disease and mentioned that the primary pathology that's happening there, or the primary brain changes that are happening there, are amyloid plaques and tau tangles. Well, in Lewy body disease, the primary pathology that has been identified is something called a Lewy body. And it's called a Lewy body because the person who first discovered this was named Fritz Lewy. And Fritz Lewy was actually living in the very same time that Alois Alzheimer was living in. So this purple arrow that just popped up here is showing you a picture of Alois Alzheimer with his lab group. And you'll see 2 people over from him is Fritz Lewy. So Alois Alzheimer was discovering amyloid and tau about the same time that Fritz Lewy was discovering Lewy bodies. Much later, in 1997, it was determined that those Lewy bodies are made up primarily of alpha-synuclein. And then the race was on. We know what the pathology is here, but how can we see it during life? It was easy to see these Lewy bodies on autopsy, but really importantly, we have to know and want to know who has these Lewy bodies while they're still alive, while we can still do something about it. And so scientists have developed a couple of tests now to allow us to identify people with Lewy bodies during life. And I'm showing you one here on the right. And there's a lot of data here, so I apologize for that, but I'll try to unpack just a little bit of it. This is showing you data for a test called seed amplification assay. And so trying to skip some of the technicality here, essentially they take a small sample of cerebrospinal fluid. This is the fluid that surrounds your brain and spinal cord and they do this through a spinal tap. So a needle is placed in your back and they withdraw just a tiny amount of fluid surrounding your spinal cord. That heals very quickly. It just takes a Band-Aid. And then they take that and they test it to see whether you have Lewy bodies in the brain. And on this graph here to the right, you can see for people with Parkinson's disease, and we see the exact same thing in dementia with Lewy bodies. The red going up there is indicating that that person does have the presence of Lewy bodies in their brain. And this is a very accurate test, and it's being rolled out sort of across the country. It's mostly used in research today, although there are some doctors' offices who are ordering this test. But again, it's so new that you may or may not be able to get insurance coverage for that. So even though this is out there clinically, we still need to learn a lot more about it before insurance companies and Medicare might start to pay for this test. I do want to mention, a little bit of difference between Alzheimer's disease and Lewy body dementia. Claire mentioned earlier about thinking and memory. That's what, you begin to lose in Alzheimer's disease. And when that gets bad enough that it interferes with daily life, that's called dementia. The same thing is true in Lewy body dementia, except that it's less likely to be memory in Lewy body dementia and more likely to be things like planning, decision making. We see a lot of changes in visuospatial abilities as well. So people may have a really hard time dealing with crowded visual presentations. So for example, looking in their drug cabinet, they can get very confused with all of the different bottles, et cetera, in there. We also see more commonly in Lewy body some neuropsychiatric symptoms. This is less common in Alzheimer's disease, but it does occur. But people who have Lewy body dementia, about 60% of them, in addition to problems with thinking and memory, will also experience hallucinations and delusions. And hallucinations, luckily, in Lewy body dementia, tend to be not scary, although sometimes they are scary. But it's very common, again, in LBD, not so much in Alzheimer's disease. And then a difference between Lewy body dementia or dementia with Lewy bodies and Parkinson's disease is that movement aspect. People who have dementia with Lewy bodies do develop, most of them do develop movement problems as they continue in the disease, but usually not full-blown diagnosable Parkinson's disease, but it's sort of a smaller version of that, if you will, called Parkinsonism. And so I left this slide in because when I was here with you last year, I told you guys about two clinical trials. One was called Shimmer, and both of these are for people with dementia with Lewy bodies. And the other one was called Rewind. And both of these were seeking volunteers last year, which is why I brought them up. Later today, I'm going to actually be able to give you some results from both of these clinical trials. So that's why I left these in here. This is my last slide, and I just want to let you know that people are also doing clinical trials for caregivers. So this is a clinical trial today called Persevere. And as Susan mentioned, her mom's health started to deteriorate when her father had dementia. we know that the caregiving is extraordinarily stressful. And so this is an intervention designed to reduce caregiver stress. Not a drug trial, but rather intensive education, support, and peer mentoring. This can also be done from the comfort of your home. No need to visit a clinic. Anyone, anywhere in the United States can participate in this study. So if you're a care partner for someone with dementia today, particularly Lewy body dementia for this study, I would encourage you to learn more about that at our website. And thank you very much, Susan, again, for giving me time to speak today.
Absolutely. And Claire and Connor, you can join us again because I just really want to emphasize all of these support services, programs, research. You can't do it without the support of all of us. And so I just really encourage everyone to support any one of these, all of these in a small way, because if we all give a little bit, it can really make a difference in the lives. And I love the caregiver thing. And I know the Parkinson's Foundation and the Alzheimer's Association have so many support groups. I mean, you can be anything and type in your criteria and boop, all these things will come up. So really utilize the resources that they're offering. But I want to talk just a little bit about, because you were talking about symptoms with Lewy body, you were talking about symptoms with Alzheimer's, and I know Connor's going to share about symptoms with Parkinson's. But a lot of questions are coming in, like, are any of them similar? I mean, you talked a little bit about Parkinsonian or that, and I know executive function is a big thing with Lewy body. I know it also is a symptom with Alzheimer's and becomes a later symptom, I think, with Parkinson's. But can Connor and Claire just share a little bit about your symptoms and how they're similar to that and how they might be a little different?
So, at least from a Parkinson's perspective, there is quite a bit of substantial overlap, especially with DLB, because as I'll mention here, the biology of these diseases is very similar in a lot of ways. So, quite a bit of overlap there, and even quite a bit with Alzheimer's as well, as we're learning more and more.
I like the hallucinations are friendlier with Lewy body.
Yeah,
If
not
that's
always. Some people do have various, so I don't want to minimize that for people. If anyone's watching, sometimes they are very scary. But for many people, thankfully, they can be not so scary.
Yeah, that's like my biggest nightmare. Claire, anything to add?
Yeah, I think just to add, I think with Alzheimer's, I think one of the challenges is that oftentimes these changes can be so subtle in the beginning that that's how they get ignored, because it's easy to sort of justify, oh, well, they were having a bad day, or, we all forget from time to time. I think when we start to see some of those, what's the difference between normal aging, where we are going to become a little bit more forgetful, or it's going to take us longer to process things. And so I think that's, again, where science and care and support are all sort of catching up with each other to make people be more informed and know that there are resources out there to ask questions, and then to be informed to ask their healthcare professionals about not ignoring some of those signs. It's better to be aware and wrong than to ignore and be right and have then something catastrophic happen that requires an unnecessary hospitalization or something else more critical.
And Julie asked a question. I'm going to do that, and then we're going to put you on, Connor. But is there a brain disorder that is associated only with loss of short-term memory?
Not to my knowledge. There might be, maybe a traumatic brain injury of some sort. I'm not particularly aware of anything that would be restricted just to short-term memory. Most of these neurodegenerative diseases, one of the most important things about them is that they are progressive, which means they get worse over time. They spread throughout the brain, more and more damage is done, and that's why you start to see the progress of these symptoms worsening over time and changing
Okay.
over time.
Okay. So Connor, we're going to put you on, and then audience, we're going to come back and really talk about research, treatment, and some scientific advances. So we're going to let Connor do his thing, and then we'll be back.
All right, are you seeing this?
We are.
All right, so I'm just going to dive right in and try to tackle the main question here, which is what is Parkinson's disease? So, at its most fundamental level, Parkinson's is a brain disease that primarily manifests as a movement disorder. So, that makes it a bit unique within the context of these three diseases. Although, as Keith mentioned, cognitive symptoms do typically develop over time. It's caused by the death of a specific type of neuron in a region of the brain known as the substantia nigra, which is located roughly around here, deep within your brain. The neurons that die within this region are responsible for producing an important chemical called dopamine. So, in healthy conditions, these neurons supply dopamine to the rest of the brain through these widespread connections that you see with these arrows. And this proper dopamine supply is what allows for coordinated movement. In Parkinson's disease, however, these neurons die for reasons that we don't fully understand yet. And therefore, these connections to the rest of the brain are lost, which leads to the movement symptoms that are a hallmark of the disease. And levodopa, the most common symptomatic treatment of the disease, is known as a dopamine replacement therapy because it attempts to replenish the dopamine that is lost in an attempt to restore coordinated movement. And while this is typically effective in the short term, prolonged use of this does lead to some rather unpleasant side effects. And just in case some of you have never actually seen a person with Parkinson's before, I have a quick 45-second video here of a patient who is showing some of the early symptoms of Parkinson's within the context of a neurological exam. You may notice a bit of resting tremor here on this right hand, or this right side, which is her affected side, as well as some issues with fine motor skills, really again on that right side, as well as some gait imbalances, which you'll see here in a few seconds. And I can confirm that these tests that you see are exactly the same ones that you would undergo in a neurological exam, as this is what my father has to do every time we go and see his neurologist. Regarding the pathology of Parkinson's, this here is an image of two brains. On the right-hand side, we have a normal brain, and what you can see is this black substance here on either side. These are actually the dopamine neurons. These neurons are filled with a dark pigment that actually makes them collectively visible as a group. And here on the left side, you can see the brain of a person who had Parkinson's, and you can see a major reduction in the amount of this black substance because these dopamine neurons have died. If we look a little bit closer at the cellular level under the microscope of a dopamine neuron, you will see just what Keith was mentioning, which is that Lewy body, this circular mass with the halo around it, which is a hallmark pathology of Parkinson's as well. And in these dopamine neurons, the Lewy body can kind of be considered a bit like a garbage dump in the brain, because what you'll find within these Lewy bodies is a collection of cellular components that are really no longer functioning properly. And importantly, within these Lewy bodies, you will also find the other major pathological hallmark of Parkinson's disease, which is the clumping of a protein called alpha-synuclein. Again, kind of what Keith was mentioning earlier. The gene that encoded for alpha-synuclein is the first gene discovered to be associated with Parkinson's back in the late 90s. And as Keith mentioned, there are many current therapies in development that attempt to target alpha-synuclein. So overall, while Parkinson's disease is best known for its movement symptoms and for the pathological hallmarks of Lewy bodies and alpha-synuclein aggregation, the truth is that Parkinson's ends up affecting many different regions in the brain as it progresses, and often has many non-motor symptoms as well, including cognitive dysfunction. So that about wraps it up for the biology. I'm actually going to stop my share and toss it back to the rest of the group.
I don't know about the rest of the audience, but I was doing so thank you for that video. That was really helpful. And I've done that walk with my mother down the hall of neurology at Stanford many times. I also understand that Parkinson's is the Um, biggest growing or of all neurological diseases, Parkinson's is one that is just really rampant. Is that true?
I believe it is true. I believe it is the fastest growing neurological disease, which is a bit scary.
It is, and we need doctors out there, so we need to encourage the doctors too. There's a question here. I'm just going to throw it to everybody. It was actually directed to you, Keith. Somebody really likes you, Ellen. But it says, does a large movement disorder along with a Lewy body diagnosis surprise any of you?
Do you mean if a person has a movement disorder and also has a diagnosis
Yes.
of Lewy body? No, that doesn't surprise me. I mean, movement is a part of dementia with Lewy bodies. So just like Connor talked about non-motor symptoms with Parkinson's, we can talk about the non-cognitive symptoms with dementia with Lewy bodies, and they're largely very similar to what you see in Parkinson's disease. So in addition to the cognitive changes, you will most likely have some movement changes. You'll also most likely have some changes in your autonomic function, which I know the word is jargon, but that means things like blood pressure drops, maybe fainting, which can be a major issue for people. People will also have another symptom domain is sleep. People frequently have problems with sleep as well. So yeah, these are, even though we think of these diseases as sometimes they're kind of hallmark symptoms, Parkinson's and Lewy body very much. I'm not so sure about Alzheimer's, but Parkinson's and Lewy body are really multi-system diseases that affect the entire body, not just what's happening in the brain.
It's interesting. My dad definitely experienced Claire sundowning, where it became very, very difficult for him to adjust from day to night. And now my mother, Connor, um, she calls me all throughout the night. She called me last night at 9 o'clock in a panic. Oh my gosh, I got to shower and get ready. I'm going to miss breakfast. I said, Mom, look outside. It's dark. It's time to go to bed. And that's almost every night. So it's so hard to watch. But Connor, a question came in for you from Sheila. Can you discuss big and loud therapies?
Big and loud therapies?
Mm-hmm. Do you know what that is?
I do not actually.
Sheila, if you want to give us a little more information, we'll try to answer your question. But here's a question for all three of you, and then we're going to jump into a couple things that we can get all excited about. Is a person's personality, so maybe someone's grumpy, maybe someone's super nice, maybe, a personality, predictive of the dementia behaviors? Claire?
So I would, just to clarify in the question, so is it predictive of the type of dementia, do you mean? You think that's what
Just,
they're asking?
if someone, always had a hard time with family members' names, they said
Okay.
short-term memory loss, aggressiveness,
Mm,
confusion,
yeah.
anxiety, fearfulness. Does that get amplified with a
Well,
dementia diagnosis?
yeah, so I think one part of that I think is important to notice, you said if someone's always had trouble remembering people's names. I think what's really important to remember, at least specifically with Alzheimer's disease, is when you're looking at the sort of characteristic of the 10 warning signs, really look at what's a change from what the person was doing 6 months or a year ago. So if there's a change in that, I was use the example, my mom was never good at remembering people's names. She had her own business and she knew faces. She knew her customers really well, but she would sometimes always get names mixed up. And I can't tell you the number of times my sister and I were probably called by the dog's name in addition
Yeah.
to each other's names. So I don't know that in her 80s, I would have been worried if she couldn't remember people's names. She was very good every day at doing her crossword puzzles. She never missed a day of doing those. And so if she started to have trouble doing even the regular level of crossword puzzle, that to me would have been a cause for concern. So I think some of the change or some of the things that if they've always been that way doesn't necessarily mean they're gonna that's dementia or that that's going to be more likely that they have dementia. But I think the other thing with the behaviors is that Everybody's just so different. And I think part of the challenge that we have in really identifying even support for some of those behaviors is that they're unpredictable. You can have a really great day and replicate that day and it not go so well. And I think that's part of the challenges that we see, that it doesn't necessarily mean that the dementia is one type or another, or it's getting worse. I think there are so many other factors that can contribute to some of those behavioral expressions. I don't know, Connor and Keith, if you would add anything there that I wasn't clear on.
Yeah, I'll jump in. I think that personality changes, are a part of all of these diseases, and some of that is based on what's happening in the brain, right? So we know that people who have Parkinson's disease, Lewy-body dementia, they have a very high incidence of anxiety. They also have a very high incidence of depression, major depression. They also have very high incidence of apathy, which is not the same thing as depression. It's a lack of motivation that's very bothersome to people who have it. It's probably also very bothersome to people around them, right? If they've been asked to help with the dishes, but they just can't get up off the couch to do that. And one of the things that's a little bit of a problem with there's a chicken and egg, issue here sometimes with when these things develop. So, for example, a person might be seen to be anxious or depressed 5 years before they get diagnosed with one of these diseases. Well, is that the anxiety and the depression predicting the development of later disease, or is it simply a manifestation of the fact that the biology is already present in the brain and it just hasn't reached the level where we can say, okay, now there's a clear movement disorder or there's clear dementia? So sometimes you pick up on those personality changes and neuropsychiatric features that happened before the diagnosis, but really might just be part of the disease rather than something that was truly present before the disease started.
Okay, I'm big and loud are physical therapy programs that concentrate on big steps and loud speech. And a couple people have chimed in here that it's fantastic therapy.
I,
Um, I'm
I
gonna,
cert yeah, I certainly support that. Diminished speech is definitely one of the symptoms with Parkinson's, so I absolutely fully support any of those treatments.
and I'm just going to answer one more question, and then we're going to jump into breakthroughs in treatment. But a question came in for everybody, and we can start with Claire and finish with Connor. Trying to plan for a disease someone's been diagnosed. What is the lifespan or approximate time that they will live with this progression of this disease? I know it varies, but if you could just
Yeah.
ballpark.
I mean, on average, they say for Alzheimer's, 8 to 12 years, but we certainly know, I think the challenge in knowing when diagnosis, the diagnosis doesn't always mean the beginning of the disease. And so for so long, people aren't necessarily diagnosed in what we would know as early stage. And so their diagnosis could come later. And I think we've also seen other comorbidities, other health issues can
Sure.
absolutely impact that number.
Sure. I mean, with falls, that's what I worry about with my mother. But go ahead, Keith, and then we'll end with Connor.
Yeah, as Claire mentioned, that this is a really difficult question because it's hard to pinpoint sort of, one point in time when did the disease begin. So usually these studies on sort of, life expectancy go from the point of diagnosis, and people might be diagnosed earlier or later in the disease process based on which disease they have, right? So if they have some very subtle symptoms early, you might not get diagnosed until much later. That being said, most of the literature would say that if you have Lewy body dementia, that you're going to have a shorter lifespan than if you're diagnosed with Alzheimer's disease. Unfortunately, the progress of the disease seems to be a little bit faster, and lifespan seems to be a little bit lower in Lewy body dementia. But again, very difficult to really nail that down.
Oh boy, I
Yeah,
know. Connor?
I think in the context of Parkinson's, it really does depend on the age of diagnosis. However, the symptomatic treatments in Parkinson's are actually quite good, and that can allow people to live relatively comfortably for many years, quite happily. So that's one of the positives of Parkinson's.
Okay, well, let's end the audience with some exciting news. Claire, let's start with you.
Yeah, so I think since we met last time, no real news other than we do have those monoclonal antibodies that are specific for Alzheimer's disease that could impact the underlying biology of the disease. We know that they do come with some risk factors, like most treatments do. And I think most exciting would be the fact that there is progress being made in really looking at how these treatments would be delivered. Right now, it's intravenously, like in an infusion, and there's advancements in looking at how we could potentially take these treatments so that they could be done potentially at home. And then I would say that there's advances in learning more and more about other drugs that could be in the horizon here of showing some promise as well.
And with the biomarker, you mentioned blood and some of the biomarkers for all these diseases, we might gain more information sooner. Is there any, and you may not be able to answer this, but a question came in, does that make you a pre-existing condition that can, be a problem with insurance down the road?
Yeah, that's a good question. And I don't, yeah, I think that's one of the questions that we don't have a really good answer for, like, what will be the impact of understanding, when we know, if you know you have some of these potential risk factors. Because I think with or have the biology of the disease, if you were to not have symptoms, I think when it comes to genetic, knowing certain genetic risk factors, it's not an absolute indicator that you will get the disease. So I think there's more for us to think about in the scientific world, and then how that translates into day-to-day care and practice for us to really understand.
Okay, and Keith?
Yeah, as far as breakthroughs go, I mean, I think the thing that I'm most excited about these days is clinical trials. Just we've had three actually phase two clinical trials report out within the last year. Now, these are phase two, so not the kinds of trials that will lead to approvals of drugs, but the kinds of trials that will lead to phase three trials. Two of them I mentioned last year and just showed you the slides earlier. Those were called Shimmer and Rewind. Both of those reported out fairly positive results. Now, Shimmer reported out positive results right away, right when they closed their study. Rewind had some positive results, but those really appeared in the open label extension portion of the study. And so, more research is needed there to be sure that that's going to still be true in a placebo-controlled phase three trial. But happy to tell you that both of the sponsors for those drugs are looking for ways forward to take those into phase three. So we're hoping to see phase three studies of both of those soon. There was another trial of a different drug that's actually a cancer drug called nilotinib, which also reported out last year, a phase two trial in people with DLB, which also had some good results. So, we're waiting to see these things published in the literature, because that will be the ultimate, kind of arbiter once they've gone through peer review. But happy to let you guys know that we're seeing some positive results in trials, and looking forward to more trials in the future using these biomarkers as well.
And just everybody, let your local government know that the research and the funding for these trials is so critical for really the future of all of us, please. And then Connor?
Yeah, so biomarker development has been really great for Parkinson's in the last couple of years as well. Keith, in his talk, already mentioned the synuclein seeding assay, which has major implications for Parkinson's as well. And we're making progress on symptomatic treatments as well, things like adaptive deep brain stimulation. I won't get into it for the sake of time, but I encourage you all to look up the potential benefits of adaptive DBS. Very exciting.
I saw that from Dr. Michele Tagliotti at Cedar-Sinai, a video. And I am not kidding you. This person had such bad tremors, and they had something implanted in their brain or something. And it was like night and day, night and day. So I encourage anybody that's having that type of symptom to look into that. But with that, we're done, and I'm so excited. So good evening on the East, good afternoon on the West. I can't thank the Alzheimer's Association and Clara Day and Keith Fargo and the Lewy-Body Association and Connor Courtney with the Parkinson's Foundation enough. And please support these wonderful foundations, associations for research, caregiver support, and all the services that we need. Thank you, everybody.
Thanks
Thank
all.
you.
Take care.